Bipolar disorder is a complex and often misunderstood mental health condition that affects millions of people worldwide, but when it comes to women, the picture becomes even more nuanced and layered. Understanding bipolar disorder in women requires looking beyond the general textbook definitions and recognizing how this condition uniquely impacts female physiology, psychology, and life circumstances. While bipolar disorder is diagnosed equally among men and women statistically, the expression of symptoms, progression of the illness, and even the path to diagnosis often differ significantly between the sexes, particularly due to hormonal fluctuations, societal expectations, and gender-specific stressors. At its core, bipolar disorder is characterized by significant shifts in mood, energy, and activity levels. These shifts can range from manic or hypomanic episodes, periods of abnormally elevated or irritable mood and increased energy, to depressive episodes marked by overwhelming sadness, fatigue, and loss of interest in daily activities. For women, these mood swings are not just emotionally distressing. They are often shaped or intensified by biological and psychosocial factors that don't affect men in the same way. In many cases, women may experience more depressive episodes than manic ones, and this pattern can lead to misdiagnosis, often being treated for unipolar depression rather than bipolar disorder. Such a misdiagnosis delays proper treatment and prolongs the emotional and functional difficulties women may face. One of the most striking features of bipolar disorder in women is the way it intersects with hormonal life stages such as menstruation, pregnancy, postpartum, and menopause. These phases are marked by significant fluctuations in hormones like estrogen and progesterone, which play key roles in regulating mood. Estrogen, for example, has been shown to influence serotonin in levels in the brain, a neurotransmitter that is deeply involved in mood regulation. When estrogen levels drop, as they do before menstruation or after childbirth, many women with bipolar disorder experience a worsening of symptoms. For some, manic or depressive episodes may become more frequent or intense around these hormonal shifts, making it harder to manage the disorder and maintain emotional stability. Moreover, the cyclical nature of a woman's hormonal system can lead to what is sometimes referred to as premenstrual exacerbation of bipolar symptoms. During the luteal phase of the menstrual cycle, which occurs after ovulation and before menstruation, some women experience heightened irritability, mood swings, or depressive symptoms. While premenstrual symptoms are common for many women without bipolar disorder, those with bipolar may find their symptoms intensify or shift into full-blown episodes. This recurring pattern can interfere with work, relationships, and overall quality of life, making it essential to recognize and address these hormonal influences in treatment planning. Another key aspect of bipolar disorder in women is the social and cultural context in which they experience and express their symptoms. Women are often socialized to internalize distress, to care for others before themselves, and to downplay their suffering in order to meet the demands of family, work, and societal expectations. As a result, many women may hide their symptoms or avoid seeking help until the condition becomes unmanageable. In addition, the way society views emotional expression in women can further complicate diagnosis. For instance, when a woman expresses intense sadness or emotional volatility, it may be dismissed as just hormones or normal stress, rather than a serious mental health condition that requires medical intervention. This kind of dismissal can be incredibly damaging and often delays proper assessment and diagnosis. Furthermore, women are statistically more likely to seek help for mental health concerns than men, but ironically, they are also more likely to be misdiagnosed. This happens in part because depressive symptoms are more visible and recognizable, while hypomanic episodes, especially when not extreme, can be overlooked or even praised as productivity or ambition. A woman going through a hypomanic phase might be seen as energetic, charismatic, or simply on top of things, and the darker implications of her mood instability might be missed entirely. Because of this, it's not uncommon for women to go years without receiving a correct diagnosis of bipolar disorder, during which time their symptoms may worsen or become more difficult to treat. The stigma surrounding mental health, especially bipolar disorder, can be particularly heavy for women. The label of being unstable or too emotional already carries negative connotations in many cultures, and a diagnosis of bipolar disorder can intensify those perceptions. This can lead to feelings of shame, isolation, or fear of judgment, all of which discourage women from opening up about their mental health challenges. Additionally, concerns about how a diagnosis might affect one's ability to parent, hold a job, or maintain relationships can cause women to resist treatment or deny symptoms altogether. Bipolar disorder manifests differently in women compared to men, not only in the frequency and type of mood episodes, but also in the subtle ways symptoms present and fluctuate. These differences often result in women receiving different diagnoses, encountering unique treatment challenges, and facing distinct psychological burdens. Understanding these nuances is essential for early recognition, accurate diagnosis, and effective treatment. The emotional and behavioral patterns seen in women with bipolar disorder can often be more complex, with increased sensitivity to interpersonal dynamics, hormonal shifts, and environmental stressors playing a significant role in shaping the course of the illness. One of the most distinctive features of bipolar disorder in women is the tendency toward experiencing more depressive episodes than manic or hypomanic ones. This pattern of depressive predominance can be misleading, as clinicians may initially mistake bipolar disorder for major depressive disorder, especially when a woman has not yet experienced a clear manic episode. Unlike men, who often present with more frequent manic episodes or mixed states, women more commonly report overwhelming sadness, fatigue, hopelessness, and disinterest in life for extended periods. These depressive states can be profound and long-lasting, significantly impacting daily functioning, relationships, and overall quality of life. The challenge here is that without recognizing the underlying bipolar nature of these depressive symptoms, women may be prescribed antidepressants without mood stabilizers, which can sometimes trigger manic episodes or worsen the course of the illness. Hypomanic episodes in women often go unnoticed or are misinterpreted because they may present in socially acceptable or even desirable ways. A woman in a hypomanic state might appear unusually productive, talkative, socially engaging, or goal-oriented. She might immerse herself in creative projects, feel a surge of energy, or engage in increased social interactions, which can all be easily mistaken for enthusiasm or confidence rather than symptoms of a mood disorder. This is especially true in professional or domestic settings, where high performance and multitasking are often praised. As a result, the early stages of bipolar disorder can remain undetected in women, particularly if they have not yet experienced a full-blown manic episode. Furthermore, women are more prone to rapid cycling, a condition where mood episodes shift quickly, 4 or more times within a year, making the illness even harder to identify and manage. Rapid cycling adds a layer of instability that can be emotionally exhausting and disrupt every area of life, from work and school to family and intimate relationships. Another unique pattern observed in women with bipolar disorder is the significant influence of hormonal changes on their mood symptoms. These hormonal fluctuations can amplify or trigger mood episodes, often creating a cyclical relationship between biological rhythms and psychological states. For instance, some women may find that their bipolar symptoms intensify before their menstrual period, during ovulation, or following childbirth. This sensitivity to hormonal changes can create a recurring pattern of instability that is difficult to predict or manage using standard treatment protocols. The postpartum period, in particular, is a vulnerable time for women with bipolar disorder. The abrupt hormonal shifts that occur after childbirth can provoke severe mood episodes, including postpartum psychosis, which is a psychiatric emergency and requires immediate intervention. Similarly, the transition to menopause, marked by declining estrogen levels, can lead to increased mood instability, anxiety, and depressive episodes, making middle age a particularly challenging time for many women with this condition. The emotional landscape of bipolar disorder in women is also marked by heightened sensitivity to interpersonal relationships and social stress. Women with bipolar disorder often report that conflicts with loved ones, breakups, or family stress are common triggers for their mood episodes. The emotional pain from perceived rejection or abandonment can quickly spiral into a depressive episode or contribute to emotional dysregulation. Conversely, feelings of euphoria, increased libido, or impulsivity during hypomanic episodes may lead to risky sexual behavior or poor decision-making, which in turn can cause feelings of guilt or shame once the episode subsides. These emotional highs and lows are not simply mood swings, but are deeply disruptive experiences that can leave lasting psychological scars. In addition to emotional symptoms, physical symptoms such as sleep disturbances are often more prominent in women with bipolar disorder. Insomnia during manic phases or hypersomnia during depressive episodes can further destabilize mood and cognitive function. Women may also experience changes in appetite and weight that fluctuate with mood states, complicating efforts to maintain physical health and further contributing to emotional distress. These somatic symptoms can sometimes be misattributed to other medical conditions, delaying the correct psychiatric diagnosis. The presence of co-occurring conditions is another aspect that complicates the symptom profile in women. Anxiety disorders, eating disorders, and post-traumatic stress disorder are commonly found alongside bipolar disorder in women, leading to overlapping symptoms that obscure the clinical picture. For example, anxiety might intensify during manic or depressive phases, while trauma-related symptoms may surface during periods of emotional vulnerability. These overlapping disorders can make it difficult to distinguish where one condition ends and another begins, requiring a comprehensive and nuanced approach to diagnosis and treatment. Hormonal fluctuations are a significant factor in the development, presentation, and course of bipolar disorder in women, making the condition particularly complex to diagnose and manage across different stages of life. These hormonal influences are not isolated to one phase, but occur throughout a woman's lifetime, from puberty to menopause, and each stage presents distinct challenges that can affect mood stability, symptom severity, and treatment outcomes. The female hormonal system operates in cycles and shifts that are deeply intertwined with the neurochemical processes that govern mood, behavior, and cognition. Estrogen and progesterone, the primary female sex hormones, play key roles in influencing neurotransmitter systems such as serotonin, dopamine, and norepinephrine, all of which are critically involved in the regulation of mood. When these hormone levels fluctuate, which they do regularly and dramatically throughout a woman's life, the delicate neurochemical balance can be disrupted, potentially triggering or worsening bipolar symptoms. During puberty, the first major hormonal shift occurs. As estrogen and progesterone levels begin to rise and fluctuate with the onset of menstruation, young women may begin to show signs of mood dysregulation. In some cases, early symptoms of bipolar disorder may be mistaken for normal teenage behavior, such as emotional intensity, irritability, or withdrawal. However, for some girls, these mood shifts are more severe and persistent than typical adolescent experiences. The emotional volatility of puberty, combined with emerging identity and social pressures, can obscure the early manifestations of bipolar disorder, leading to underdiagnosis or misdiagnosis during a critical developmental period. Additionally, because teenage girls often face stigma or dismissal regarding their emotional states, frequently being told they are simply hormonal, in psychiatric symptoms may be overlooked or minimized by caregivers and healthcare providers. As women move into their reproductive years, the menstrual cycle becomes a regular source of hormonal variation. Many women with bipolar disorder report that their mood symptoms follow a cyclical pattern that coincides with their menstrual cycle. Specifically, the premenstrual phase, which is marked by a decline in estrogen and progesterone, is often associated with a worsening of depressive symptoms, irritability, and emotional instability. This premenstrual exacerbation can make it difficult for women to maintain emotional equilibrium throughout the month and may contribute to a cycle of instability that affects work performance, interpersonal relationships, and overall well-being. Some women may even experience premenstrual dysphoric disorder, PMDD, alongside bipolar disorder, a condition characterized by severe mood symptoms prior to menstruation, further complicating diagnosis and treatment. Pregnancy introduces another dramatic hormonal shift, with levels of estrogen and progesterone rising exponentially to support the developing fetus. For some women with bipolar disorder, pregnancy is a period of relative emotional stability, possibly due to the protective effects of high estrogen levels. However, for others, pregnancy can trigger mood episodes, especially if they have discontinued their psychiatric medications due to concerns about fetal safety. The decision to stop or continue mood stabilizing medications during pregnancy is fraught with difficulty, as many medications used to treat bipolar disorder carry potential risks to the developing fetus. Yet, untreated bipolar disorder also poses risks, including poor prenatal care, substance use, and suicidal ideation, all of which can endanger both the mother and the baby. The need for close psychiatric monitoring and personalized treatment planning during pregnancy is essential to minimize these risks and support maternal mental health. Perhaps the most vulnerable hormonal phase for women with bipolar disorder is the postpartum period immediately following childbirth. After delivery, estrogen and progesterone levels plummet dramatically, creating a sudden hormonal vacuum that can destabilize mood. For women with bipolar disorder, this period is associated with a heightened risk of severe depressive episodes, manic episodes, or even postpartum psychosis, a rare but life-threatening condition characterized by delusions, hallucinations, and impaired reality testing. Postpartum psychosis is a psychiatric emergency that requires immediate intervention to protect both the mother and the infant. Even in the absence of psychosis, many women experience a relapse of bipolar symptoms in the weeks and months following childbirth, making it one of the most critical times for mental health intervention and support. As women age, the transition to menopause presents yet another significant hormonal upheaval. The perimenopausal phase, which can last for several years, is characterized by irregular menstrual cycles and fluctuating hormone levels. Many women report increased mood instability during this time, including heightened irritability, anxiety, depressive symptoms, and disrupted sleep, all of which can exacerbate underlying bipolar disorder. The loss of estrogen during menopause can lead to changes in brain function, particularly in areas responsible for mood regulation, memory, and executive function. For some women, the drop in estrogen acts as a trigger for new or worsening mood episodes, necessitating a reevaluation of treatment strategies that may have previously been effective. Hormone replacement therapy (HRT) has been explored as a potential adjunct treatment in some cases, but its use remains controversial and must be carefully weighed against individual health risks and psychiatric history. In each of these life stages, hormonal changes act as both a catalyst and a complicating factor in the expression of bipolar disorder. The challenge lies not only in identifying the role of hormones in mood instability, but also in developing treatment plans that account for these biological shifts. Because the impact of hormonal changes on mood is so individualized, it requires clinicians to take a highly personalized approach to managing bipolar disorder in women. This includes considering the timing of mood episodes in relation to menstrual cycles, planning for psychiatric care during pregnancy and postpartum, and addressing the unique challenges of menopause. Misdiagnosis and gender bias play a profound role in how bipolar disorder is recognized, understood, and treated in women, often resulting in delayed care, inappropriate treatment plans, and prolonged suffering. Mental health diagnoses rely not only on symptomatology, but also on how those symptoms are interpreted by clinicians, shaped by cultural narratives, and influenced by unconscious biases. In the case of women with bipolar disorder, these biases can lead to a pattern where their experiences are trivialized, misattributed to other conditions, or misunderstood entirely, especially when their symptoms diverge from textbook male-centric models of mental illness. One of the most frequent issues women face when seeking help for bipolar disorder is the misdiagnosis of major depressive disorder. Because women with bipolar disorder tend to experience more depressive episodes than manic ones, they often seek treatment during a period of deep sadness, hopelessness, or fatigue. These symptoms overlap heavily with unipolar depression, and without a detailed exploration of mood history or hypomanic episodes, a diagnosis of bipolar disorder can easily be overlooked. Clinicians might fail to ask whether the individual has ever experienced unusual periods of high energy, decreased need for sleep, or impulsive behavior, especially if the woman herself does not recognize these experiences as problematic or related to mental illness. This lack of detailed inquiry is frequently rooted in time constraints during medical appointments, a lack of specialized training, or assumptions that women are simply more prone to emotional instability. Gender stereotypes further compound the issue. Society often views women's emotions as inherently more volatile, labeling emotional expression as typical rather than indicative of a deeper mental health concern. This stereotype can desensitize healthcare providers to the severity of a woman's symptoms, particularly if she presents with irritability, tearfulness, or anxiety. In some cases, these symptoms may be dismissed as hormonal or situational, such as stress from parenting or work-life balance, instead of being taken seriously as clinical signs of a mood disorder. As a result, women are often not referred for comprehensive psychiatric evaluations or are prescribed medications that only partially address their needs, such as antidepressants without mood stabilizers, which can exacerbate bipolar symptoms or trigger manic episodes. Moreover, the tendency to pathologize women's behavior differently than men's contributes to skewed diagnostic outcomes. When a man presents with irritability, grandiosity, or risk-taking behaviors, these may be interpreted through a lens of pathology and lead to a diagnosis of bipolar disorder. In contrast, similar behaviors in women are more likely to be viewed as character flaws, moral failings, or the result of relational conflict. This bias can lead to women being labeled as difficult, overly dramatic, or emotionally unstable, often delaying appropriate diagnosis and treatment. In some instances, women are misdiagnosed with personality disorders, most commonly borderline personality disorder, because of overlapping symptoms such as emotional dysregulation, impulsivity, and mood swings. While these conditions are distinct in both origin and treatment, the failure to accurately distinguish between them can result in years of ineffective therapy and medication, compounding the woman's distress. Healthcare systems themselves may inadvertently reinforce these patterns through the design of assessment tools and diagnostic criteria that reflect predominantly male presentations of bipolar disorder. Historically, research on bipolar disorder has been skewed toward male participants, meaning that clinical understanding of the disorder has been based on male-centric symptoms and trajectories. Consequently, women whose symptoms deviate from this model, by being more depressive, mixed, or rapid cycling, may not fit neatly into diagnostic categories. They fall through the cracks, untreated or mistreated, as the medical community continues to rely on frameworks that do not reflect their lived experiences. In addition to structural and diagnostic biases, women often encounter dismissiveness when they attempt to advocate for themselves. Women who express concern about the effects of psychiatric medications, report worsening symptoms, or question their treatment plans may be perceived as non-compliant or ungrateful rather than as informed patients with legitimate concerns. This dynamic creates a barrier to trust between women and their healthcare providers and may discourage them from seeking help in the future or being forthcoming about their symptoms. For women of color or those from marginalized communities, these issues are often magnified by additional layers of racial, cultural, or socioeconomic bias, making diagnosis and treatment even more inaccessible. Furthermore, the stigma associated with mental illness is often more intense for women, particularly those who are mothers or caregivers. Society places unrealistic expectations on women to be emotionally resilient, nurturing, and composed at all times. Admitting to mental health struggles can lead to fears of being judged as unfit mothers, incompetent professionals, or unstable partners. These fears can prevent women from disclosing symptoms honestly or pursuing aggressive treatment, further delaying accurate diagnosis. When women do seek help, their narratives may be filtered through a lens of gendered expectations, where expressions of emotional distress are seen as less credible or more exaggerated than if they were presented by men. Ultimately, the misdiagnosis and gender bias that pervade mental health care create a cycle of misunderstanding, mistreatment, and mistrust that is difficult to break. Until mental health professionals, institutions, and society as a whole recognize the gendered dimensions of psychiatric diagnosis and care, women with bipolar disorder will continue to face barriers that compromise their well-being and diminish their quality of life. Treating bipolar disorder in women presents a unique set of challenges, particularly when it comes to medication sensitivity, hormonal fluctuations, and life stage-related considerations. While pharmacological treatment is often essential in managing bipolar disorder, women frequently experience more pronounced side effects and different responses to medications compared to men, which can complicate the process of finding an effective and tolerable treatment regimen. Understanding these gender-based nuances is critical to ensuring women receive appropriate, sustainable, and compassionate care. One of the most consistent findings in psychiatric research is that women tend to be more sensitive to the side effects of psychotropic medications. This heightened sensitivity may be linked to biological differences such as body fat composition, metabolic rate, and hormonal interactions, all of which can influence how drugs are absorbed, distributed, metabolized, and excreted. For example, mood stabilizers like lithium, which are considered a cornerstone in bipolar disorder treatment, must be closely monitored in women due to their effects on thyroid function and kidney health, two systems that women are already more vulnerable to in terms of dysfunction. Women are also more likely to develop hypothyroidism as a side effect of lithium, which can exacerbate depressive symptoms and create confusion in the diagnostic and treatment process. This can result in a frustrating cycle where the very medication intended to stabilize mood may worsen aspects of the condition if not carefully managed. Antipsychotic medications, often used to control manic episodes or supplement mood stabilizers, also pose unique challenges for women. These medications can cause significant weight gain, metabolic syndrome, and menstrual irregularities, which may be more distressing for women and impact their willingness to remain on treatment. Additionally, some antipsychotics can elevate prolactin levels, leading to breast tenderness, galactorrhea, or disrupted menstrual cycles. These side effects, while sometimes downplayed in clinical settings, can significantly affect a woman's quality of life and body image, making adherence to treatment less likely over the long term. The emotional and physical toll of such side effects often goes underrecognized, especially when women are expected to prioritize symptom control over well-being or are not fully informed about the range of possible medication impact. The reproductive life cycle introduces further complications in treatment management. Women of childbearing age face the added challenge of balancing the need for effective mood stabilization with the potential risks that psychiatric medications pose to fetal development. Many mood stabilizers, such as valproate and carbamazepine, are known teratogens associated with neural tube defects and other congenital abnormalities. This risk creates a dilemma for women who are pregnant or planning to become pregnant, as they may be advised to discontinue or alter their medication regimen, often with significant destabilization of mood as a consequence. Even medications considered relatively safer during pregnancy, such as certain atypical antipsychotics or lamotrigine, still carry some degree of risk and must be used cautiously under expert supervision. The constant recalibration of medication around reproductive decisions, including fertility treatments and birth control use, places an additional emotional and logistical burden on women navigating bipolar disorder. Hormonal shifts throughout the menstrual cycle, during pregnancy, and at menopause can all influence how medications work and how symptoms manifest. For instance, the premenstrual phase, characterized by declining estrogen and progesterone levels, may coincide with increased mood instability and altered medication responsiveness. Some women find that doses which are effective at one point in the cycle are less effective during another, leading to a perceived inefficacy of treatment or a need for constant adjustments. This cyclical pattern is rarely considered in traditional treatment models, which tend to assume steady state conditions rather than fluctuating physiological environments. As a result, women may be unfairly labeled as non-compliant or treatment resistant when the true issue lies in the dynamic interaction between hormones and medication efficacy. The perimenopausal and menopausal phases bring yet another layer of complexity to medication management. Estrogen levels begin to decline, potentially influencing the effectiveness of certain mood stabilizers or antidepressants, and leading to a resurgence of mood symptoms, even in women who have been stable for years. In some cases, hormone replacement therapy may be introduced to help mitigate mood disturbances, but this option is controversial and must be tailored carefully to the individual's psychiatric and physical health history. The interrelationship between declining estrogen, changing medication response, and the psychological impact of aging can make this life stage especially difficult for women with bipolar disorder. Psychological and social factors also intersect with medication challenges in unique ways. Women are more likely to be primary caregivers, manage household responsibilities, and maintain emotional labor in relationships, all while managing their own mental health. These roles can make consistent medication adherence more difficult, especially when side effects interfere with daily functioning. For example, excessive sedation caused by certain medications can hinder a woman's ability to work, parent, or engage in social interactions, leading to decisions to reduce or stop medication altogether without medical guidance. The need to feel like oneself, again, or to be fully present in caregiving roles often drives such decisions, even when the cost is an increased risk of relapse. Another challenge lies in the interaction between psychiatric medications and other treatments that women may be prescribed for co-occurring conditions. Many women with bipolar disorder also struggle with anxiety disorders, chronic pain, or autoimmune conditions, all of which may involve medications that interact negatively with mood stabilizers or antipsychotics. The potential for drug interactions is higher in women due to the likelihood of being prescribed medications across multiple domains, necessitating a more integrated and collaborative approach to care, something that is still lacking in many healthcare systems. Furthermore, social stigma and internalized shame around taking psychiatric medication can weigh heavily on women, who are often socialized to appear emotionally balanced, nurturing, and composed. Taking medication for a mental health condition may conflict with these societal expectations, leading to guilt, secrecy, or even a refusal to accept treatment altogether. This stigma is compounded when a woman experiences visible side effects such as weight gain or tremors, which can alter how she is perceived by others and affect her self-esteem. Addressing these concerns requires a more holistic, empathetic approach from healthcare providers, who must take the time to validate women's experiences, explore alternative treatments when necessary, and ensure women feel empowered to participate in decisions about their care. Living well with bipolar disorder as a woman requires more than just medical intervention. It involves a comprehensive support system, adaptive coping strategies, and a personalized lifestyle approach that acknowledges the complexity of the condition. Managing the highs and lows of bipolar disorder is often a lifelong endeavor, but with the right resources and self-awareness, many women can achieve stability, maintain fulfilling relationships, and pursue meaningful careers and personal goals. The key lies in developing resilience through support structures, emotional regulation techniques, and a deep understanding of one's own mental health landscape. Social support plays a crucial role in the well-being of women living with bipolar disorder. Having a network of people who provide consistent encouragement, practical assistance, and emotional reassurance can make a substantial difference in managing symptoms and preventing relapse. This support can come from family members, close friends, romantic partners, or community members who are educated about the condition and genuinely invested in the woman's well-being. Unlike temporary encouragement, ongoing support can create a buffer against the emotional volatility associated with bipolar disorder. It helps mitigate the feelings of isolation and alienation that often accompany depressive or manic episodes. However, it is also important for the support network to be well, in formed about the nature of bipolar disorder to avoid misunderstandings and prevent well-intentioned but harmful interventions. Therapeutic alliances are equally important. A long-term engagement with a compassionate and competent therapist can provide a safe space to explore emotional triggers, examine distorted thought patterns, and develop coping mechanisms tailored to each phase of the disorder. Cognitive behavioral therapy (CBT), dialectical behavior therapy (DBT), and interpersonal and social rhythm therapy (IPSIT) have shown particular promise in helping women navigate mood fluctuations, manage interpersonal challenges, and regulate their daily routines. Therapy not only offers emotional insight, but also equips women with practical tools to recognize early warning signs of manic or depressive episodes and intervene before these episodes become debilitating. When therapy is combined with psychoeducation, women often report greater confidence in their ability to manage the disorder and make informed decisions about their care. One of the most effective long-term coping strategies for women with bipolar disorder is the establishment of a stable and predictable daily routine. Disruptions in sleep, eating habits, or daily schedules can trigger mood episodes, particularly for those with a more sensitive circadian rhythm. Prioritizing consistent sleep and wake times, regular meals, and structured activity periods can promote internal equilibrium. Many women find that incorporating relaxation practices such as mindfulness meditation, deep breathing exercises, and gentle movement like yoga or Tai Chi helps reduce stress levels and increase emotional resilience. Engaging in creative outlets such as writing, painting, or music can also serve as a therapeutic form of self-expression and an alternative way to channel intense emotional energy. Lifestyle choices around diet, exercise, and substance use are particularly influential. Nutritional habits that support brain health, such as eating foods rich in omega-3 fatty acids, vitamins, and antioxidants, can enhance mood stability and cognitive function. Regular physical activity has been linked to improvements in mood and sleep quality, and even moderate forms of exercise like walking can make a notable difference. Avoiding alcohol and recreational drugs is essential, as these substances can disrupt the effects of medications and intensify the symptoms of bipolar disorder. Many women also benefit from reducing or eliminating caffeine, which can exacerbate anxiety and interfere with sleep, particularly during hypomanic or manic periods. Women with bipolar disorder often face unique stressors related to gender roles, caregiving responsibilities, and societal expectations. Coping well includes setting boundaries and learning to say no to obligations that overwhelm their emotional bandwidth. This may involve communicating openly with loved ones about limitations, carving out time for self-care, and practicing assertiveness without guilt. Stress management strategies such as journaling, time management techniques, and prioritization of rest are important tools to incorporate into daily life. Over time, these strategies contribute to emotional stability and empower women to take control of their mental health journey rather than feeling controlled by it. Peer support groups offer another avenue for empowerment and healing. Being part of a community of individuals who share similar challenges provides a sense of validation and belonging that can't always be found elsewhere. Hearing other stories, exchanging coping tips, and celebrating successes together can inspire hope and reduce feelings of shame or self-stigma. Whether in person or online, support groups can serve as lifelines during particularly difficult periods and as sources of motivation to continue progressing through the recovery process. For many women, these connections offer practical insights and emotional solidarity that traditional therapy alone may not provide. In addition to personal coping strategies, advocacy and education play an important role in creating a supportive environment. When women openly talk about their experiences, share resources, or participate in mental health awareness efforts. They help dismantle the stigma surrounding bipolar disorder and encourage others to seek help. Education fosters understanding in workplaces, families, and communities, which in turn makes it easier for women to access accommodations, retain employment, and maintain relationships even while managing the disorder. This advocacy also includes pushing for greater gender, sensitive research, and more inclusive mental health services that consider the unique physiological, emotional, and social needs of women. Ultimately, living well with bipolar disorder means embracing a model of wellness that goes beyond symptom management. It involves nurturing emotional intelligence, cultivating purpose and meaning, and adapting to life's inevitable changes with flexibility and grace. Women with bipolar disorder often develop profound insight into the human condition, empathy for others, and an inner strength that comes from navigating extreme emotional landscapes. By integrating medical care, social support, therapeutic tools, and self-directed wellness practices, women can build a life not defined by bipolar disorder, but enriched by the wisdom and resilience that come from living with it. Living with bipolar disorder as a woman presents unique challenges. But with the right support, treatment, and coping strategies, it is entirely possible to lead a stable and fulfilling life. Understanding the gender-specific nuances of the disorder empowers women to take control of their mental health journey. Access to informed care, consistent routines, and strong social networks can significantly improve long-term outcomes. Advocacy and education help reduce stigma and foster a more compassionate society. With resilience and the right tools, women can thrive beyond the diagnosis.